Hello, everyone. Hope you all are doing great. So this side, Asma, I'm here to give you the overview of all the courses that Medicine Expert is offering you for your best preparation. So we have a team of amazing mentor. We have Dr. Sumaya, we have Dr. Farhad Joya, we have Dr. Nabira Khan, all the amazing mentors to guide you in your AMC-1 journey. So let me just give you an overview about our courses that Medicine Expert is offering. So we have amazing courses for all the students out there, like all the students who are starting their preparation from scratch or the students who just want the revision. We have all the amazing courses for all the students out there. So now what we are going to offer is we are offering our regular course and the we call crash course. And what's the difference? So all the students who are going to start their preparation from scratch, we recommend them the regular course. And what is that? That includes 42 live sessions of all the important topics that you consider important for your AMC-1 preparation. Then apart from the live sessions, we have the recordings and the PDFs that we provide on the, when there is a live session on the very next day, we provide the recording along with the PDFs. Then we provide you the AMC question bank that contains 5,000 plus questions from the recalls, from all the important scenarios that you can think of that can come in your exam day. Then we have the quizzes that will really help you to practice different questions before your actual exam. Then we are going to provide you the recall quizzes so that instead of reading the recalls, you can perform the recalls in the form of quizzes on our website. Then we are going to provide you the notes and the flashcards. They are going to help you in your theory preparation. Then we also provide the solved recall files. So it will be a complete package for the students who are starting their preparation from scratch. The duration of this course will be 4 months, and the course will be starting from 1st of October. And then let's talk about our recall crash course. So in our recall crash course, there will be 15 interactive live sessions. In those live sessions, we are going to cover all the topics. We are going to do question discussion. We are going to solve all the important scenarios so that you can practice as much as questions as you can. Then we are going to again provide you the recording and the PDF of the live sessions because we do understand the duties and the daily, your activities. So to accommodate that, what we do is we provide the recording of every live session. So in case you miss any live session, you're going to get the recording and the PDF on the very next day of the live session. Then we have specially designed your psychiatry workshop. And what's this that? In the psychiatry workshop, we are going to conduct 5 live sessions for psychiatry specifically. And then we're going to provide you the quizzes and the topic tests for psychiatry so that your module for psychiatry will be well prepared. Then we have added the recall sessions, the recorded recall sessions, so that in case you want to practice some recall questions, then you can watch the recordings as well. Then we're going to provide you the PDFs of all the solved recall files so that you know what AMC is expecting from you and what kind of questions AMC always gives. So you can practice as much as questions as you can. And similarly, I explained to you about the question bank, the mock exams, everything is added in this crash course, and it will be a 3-month course. So you will get, best preparation after attending this course. So this is the schedule of our recall crash course. We have the amazing mentors, Dr. Sumaya, Dr. Farhad, and Dr. Nabira, who's going to be your mentors for this course. And then what we have done is in the 3 months, we have divided the course in modules. Like we're going to start with medicine module, then surgery, then obs, then gynae. We will cover every module in this crash course. So in the first module, we're going to start with medicine, in which we are going to conduct 2 live sessions for the medicine with Dr. Samaya and Dr. Farhad. And then on the rest of the days, when there is no live session, we are going to provide you a topic test that you have to perform on the website or the application, whatever you want to use. And then after your medicine module will be completed, then we are going to provide you the medicine recalls that will be provided to you in the study group on the WhatsApp. And then on the very next day, we're going to have a mini mock for medicine so that your medicine module will be properly prepared. And then by the end, we are going to have a group discussion that will be conducted by Dr. Aisha Iftikhar in the study group again, so that your one module will be properly completed. Then we're going to move to the second module that will be surgery, then obs. Similarly, we are going to cover each and every module so that your whole modules will be completed. And by the end, we are going to provide you 3 mock exams that will really help you to ace the exam before your actual exam. Okay, it will be just like your real exam, so you can have an experience about how AMC gives and how you can solve the questions. So these are the reviews from our amazing students who have joined us for the August batch. These are some of the emotions that they have shared towards MedExam Expert. You can also check the reviews from our Facebook page of MedExam Expert as well, so that if you want to check the reviews of the students who have joined our courses, you can check the reviews from there. These are the amazing reviews that our students have given us when they joined the sessions. They have shared their amazing emotional reviews with us. These are some of the reviews from our amazing students who have passed the exam. Also, we do provide bundle offers as well. For example, if you want to join the regular course and the recall crash course, or if you want to join the regular course plus exam week sessions, then we have special discount for all the students who want to join the 2 courses or 3 courses. Then we do provide discount. If you want any details about this thing, you can just message us. We are always here for your help. So, Dr. Nabila, are you here?
Yes, Asma, I'm here.
Yeah, I guess students are waiting for your recalls and all your guidance. So I guess we can start now.
Yes, sure.
Yes, Dr. Nabila, we can start now.
Okay. Hello, everyone. How are you all? How's your preparation going? It's basically an interactive session. You can ask me the questions about anything regarding AMC journey, and even we will do a very good topic today regarding the emergency, the trauma, the settings, the most backbone of the AMC. We can say that most of the questions from the emergency, how you manage the patient over there, how they will you will approach the patients. What type of emergencies you will be deal when you once pass the exam and then go to the Australia. So there are a lot of questions from that topic. So I choose this topic for you guys. Okay, so the basic from the where the emergency started is about the BLS, the ACLS. I guess most of you students have been done once in their life as well, in the clinical setting or in your the workshop as well, right? So, in any emergency event demanding immediate medical attention with rapid assessment because of the time critical, we have to we go with the airway first, as we know that basic life support. What we will do to say, see the airway, breathing, circulation. We can also go for the CD and E as well. That we have to expose the patient as well, right? So these are the basics. What are the significance, like why we are going just for the CPR first, and why it's very important setting all over there, like without doing ACLS and BLS you cannot even get a job as well, because it's the basic requirement, because we have the two main organ that require oxygen every time. One and foremost will be the brain, and other will be the heart. If you didn't even pump, and if you didn't even do the circulation, the brain cells will be dead. Like even you cannot do CPR properly, after the some time, your brain cells will be dead. So there will be no clue if you save the patient just from applying the oxygen, but if you don't give the breathing, that will be go and circulate to the brain. The brain will be dead, and that patient will be going the stroke, and that patient having hemiparalysis for the whole of the life. See, so the mortality rate around this will be the 55,000. Almost 9,000 Australians die of heart attack, and 24 Australians die from the heart attack each day. So this is the survey. Okay, so most commonly emergencies we will see in the emergency department, or we will discuss, and what the patient, they will ask in the questions, and what they will ask in the AMC clinical exams. I'll cover from both sides of this topic. So we will start from the topics, what the common emergencies we will deal with, right? So we will divide it with the primary care and the child care. In both settings, you will see the asthma exacerbations. In primary care, you can see the psychiatric emergencies that will be related with the drug emergencies as well. In the primary care, you can see the seizures. Seizures are the very, very important. You have to rule out either it is from the meningitis, either it is from the sepsis, or either it is from the electrolyte imbalance. Because most of the electrolyte imbalance can cause the seizures, especially in old age. Okay, hypoglycemia can also induce the seizures. We will go for the anaphylaxis, that apnea, because peanut allergies, most of the allergies are very common over there. Impaired consciousness, or we can say altered level of consciousness due to anaphylaxis, either from the orthostatic hypotension, either from the any drug reaction, or it will due to any opioid poisoning, or it will due to any type of drug overdose as well. Another thing is the shock. The shock will be from either from the road traffic accident, a patient will go in the hypovolemic shock, or it will go in the cardiogenic shock. We will deal with that thing as well. Poisoning. Poisoning is very, very important, because you will see the organophosphorus poisoning. You will see about the opioid overuse. There are a lot of questions from poisoning, as well as the poisoning chapter also contain the spider bite, the blue jellyfish as well. These are very important over there. Drug abuses, drug overdoses, and cardiac arrest. Also in children, you will find the foreign body that will be stuck. That question will come either it is from the lead battery that will be in the nostrils, or there will be a foreign body in the epiglottis, or sometime in the esophagus as well, and they will ask you the management. So these are the main questions that will be asked in the portion of AMC regarding the ED. Okay, so this is the basic life support, that what you will do and when you will start the CPR, and how many compressions you will give. They will sometime ask the 30 compressions and 2 breath. Just remember the rate, because in some BCQs they will ask the rate. So rate will be the 100 and 120. If you exceed the rate, that will be the too rapid. And if you not giving that depth, that will be the too slow. That patient will not be revived from that. So remember the rate will be the 100 and 120. Between 100 and 120, compressions will be 30, and you have to give 2 breaths. So these are the basic things you have to remember that. Okay, the purpose of CPR is to temporarily maintain a circulation sufficient to preserve brain function until unspecialized treatment is unavailable. Commence CPR only if victim is unresponsive and not breathing normally. Universal compression ratio is 30:2 for all age. Risk of disease transmission is very low, like hepatitis B, C, HIV, or cytomegalovirus. So these are the parameters that will be important for you, because in sometimes they will ask in the MCQ portion that for the depth in children and adult 5 centimeter, and in infant you have to go for the 4 centimeter when you give the compression. So these are the depth. Hand position too high is ineffective, too low may cause regurgitation and damage. Risk of CPR, it will be one risk, like you will fracture the ribs, and other injuries are common, but acceptable consequence of CPR given the alternative death, right? Okay, CPR in pregnant woman, place a towel cushion under the right hip to tilt the victim's hip slightly, approximately 15 to 30 degree to with the left, with shoulders flat. The reason for this position is pregnant woman is to move the weight of the pregnant uterus of the victim's major blood vessels in the abdomen. Remember this thing, because sometimes they ask about the pregnant woman CPR, because it's very different from the other of the things. Okay. So ED is automated external defibrillator used in adult and children only if unresponsive and not breathing normally. CPR must be continued until the ED is turned on and pads attached. Once the ED is identified the shockable reading, then they will ask you to clear the field, right? ED can also be used on pregnant victims as well. You have to mark it because most of the time people say that it's a contraindication for the pregnant woman. No, it's not the contraindication, right? So defibrillation safety, do not touch the victim during the shock. You have to clear the field and deliver the shock. Once you deliver the shock, you have to do CPR again. So for the pad placement for the adult, expose chest in anterior position, pad to skin contact, remove moisture or excessive chest hair if it's possible. Place pad at 8 cm from the implanted devices and remove medication patches. In children, standard adult AEDs and pads are used for children older than 8 years. Between the age of 1 and 8 years, pediatric pads and pediatric mode are used for the ED. Like there are two type of EDs. There's adult EDs are different, and for the pads they will be different because there is a difference between the voltage as well. The standard adult ED and pads can be used. Pads should not touch each on the child's front and back position. Okay, so ACLS is basically the advanced form of BLS. Like after you have saved the patient for BLS, you will go for the ACLS. For ACLS, you have to be very, very good in the ECGs because ECGs questions are also asked in the exam as well, right? They will give you different type of ECGs and they will ask you to identify it. Sometimes they will ask you to give the treatment of this. So for the ALS, you have to remember that there are two types of rhythm and you have to remember this rhythm because most of the ECGs will come from these type of rhythms. We have two types of rhythm. One is shockable rhythm and another is non-shockable rhythm. In shockable rhythm, you have two types of rhythm, basically ventricular fibrillation and pulseless ventricular tachycardia. There's sometime they will give you this question in the exam with the ECG and they will ask you that this patient goes into this, identify the rhythm. So from the ECG and from the whole scenario, you have to identify whether it is ventricular fibrillation or ventricular pulseless ventricular tachycardia. Remember this thing that you have to remember there's not only the pulseless ventricular tachycardia, we have the even without even pulse, we have supraventricular tachycardias as well. So remember this thing, it is important because when you see the cardiology chapter, they will give you lots of ECGs regarding this thing. And also the treatment is changed in both pulseless rhythm and non-pulseless rhythm, right? And in non-shockable rhythm, we will have two, asystole and pulseless electrical activity. Remember this thing or try to mark in any book or something. What we say that pulseless electrical activities either can be atrial fibrillation, any rhythm that have no pulse, we will say that pulseless electrical activity. It can be a fibrillation as well. It can be SVD sometime as well. It can be anything. If you see them on the monitor, there's no pulse and there's electricity going or either it is AFib or something, you have to mention it. It is pulseless electrical activity because most of the people can recognize asystole because in asystole there's a flat line, right? But a pulseless electricity, they will always mark that it is AFib. They will mark that it is SPT. No, if you see that there is no pulse, how you will mark that it is AFib? You have to remember that you have to mark it. It is pulseless electrical activity. Okay, so this is a chart. We can even do what because most of the time AMC will just give you this chart in the MCQ and ask you. For example, they will say that there is a 13-year-old boy who will in the restaurant and just we can say unconscious after eating something. The rhythm is shockable. What you will do next? So in the question, they ask you like this. So you have to remember that it is a shockable rhythm. So you have to give the shock. And sometimes they say that the shock is given and the CPR is initiated after 2 minutes. What you will do? So after 2 minutes, you have to do the CPR as well. And you have to give shock. After giving the 2 shock, you have to start with the epinephrine. So sometime in the question, they say that in the person who is having a shockable rhythm, 2 shock already giving. And after assessing the pulse, there is no pulse. What you will do next? So after the 2 shock has been delivered, you have to give the epinephrine. and you have to repeat the epinephrine every 3 to 5 minutes. This is very, very important because in scenario, sometimes they said that 2 shocks are already given and the epinephrine is already given. What you will do next? So after the 2 shock and epinephrine, you have to go for the amiodarone or lidocaine. And after this, every 2 to 3 minutes, you have to give epinephrine, and after 2 to 3 minutes, you have to check the pulse activity. So because if the pulse is reverted or something happens or the rhythm changes from shockable to non-shockable, the treatment will be changed. So in the questions, they will ask that a patient came to you and the rhythm is shockable. We already gave the 1 shock. What you will do? So you have to deliver another shock. But if they say that 2 shocks are already given, what you will do next? So you have to go for the epinephrine. And sometimes they say that shock is already given, epinephrine is also given. What you will do? Then you will go for the amiodarone or lidocaine. So that's the way they will ask for the shockable things. And if you remember this advanced support flow chart, it will be very, very easy for you guys to solve these questions. Because shockable rhythm have different things and non-shockable rhythm have different things. If, for example, they give you some ECG and it will be from asystole, there's a flat line. They will say there's a 40-year-old male on the roadside. You will attach that AED and they will give you the asystole. What you will do? So in the pulseless activity or in asystole, you have to give epinephrine as soon as possible. And after giving epinephrine, you will start the CPR, right? And you have to repeat the epinephrine every 3 to 5 minutes, and then you have to see either the rhythm is shockable or non-shockable. Because shockable rhythm you have to give the shock, and in the non-shockable rhythm, you have to give epinephrine, and then you have to start with the CPR. So this chart is important to memorize it because 1 or 2 questions from the CPR will come in the exam. This is the traumatic cardiac arrest. Like if the patient goes in the cardiac arrest, what you will do? It is cardiac arrest chart that is visible over here. Same, you have to, what you have to do, you have to start the CPR after the cardiac arrest as well. You have to divide the things into 2 things. That will be you have to, first and foremost thing you have to do is you have to check the rhythm. Either it is giving a ventricular fibrillation, pulseless ventricular activity, asystole or PE. That will be that rhythm or that ECG will be given in the exam and they will give the scenario. From the ECG, you can recognize it either it is shockable or non-shockable because sometimes they don't give you the shockable, non-shockable, they will give you the ECG. If there is only a flat line, there will be asystole and asystole will be go for the pulseless electrical activity. So you have to give epinephrine. So the treatment will be changed. And if you recognize that the ECG is giving about the ventricular fibrillation, in ventricular fibrillation, there is no QRS complex. There is a zigzag line like this. So you have to remember that in ventricular fibrillation, you have to give the shock. So they will just give you sometime ECG and they will sometime mention the rhythm. According to that, you have to give the treatment. Okay, and for the AMC exam, you have to focus on the diagnosis, techniques, and indication and management. So there is an MCQ for your practice. A 53-year-old man with a ventricular fibrillation cardiac arrest is undergoing advanced CPR in the emergency department. He has received adrenaline 1 milligram 1 minute ago and has just received DC shock of 200 joules. He remains in VF. What is the next step? Now I want you guys to participate and give the answer. What is the next step?
Shock again.
Okay, let me also show you this slide as well. Now you can answer it better. Remember one thing, during you are giving the epinephrine, after just giving the epinephrine, you have to do CPR as well. Like you cannot leave a patient that I just give the epinephrine and there is no CPR. No, for give CPR, epinephrine is given or amiodarone, any drug can be given from the IV assist, right? You never have to stop the CPR. You can only stop the CPR while you are assessing for breathing. You cannot stop the CPR while you are doing any drug or something. And when you are giving shock, there's a two condition when you leave the patient without chest compression. One is when you are giving the shock, you have to clear the field. Another is when you are assessing the circulation or you're assessing the breath. Like you have to put your fingers on the carotid. If you are doing CPR and you are assessed for the pulse or anything, that will be give you the false result because from the compression you are just getting the pulse. So you have to stop the compressions while you are assessing the pulse, right? I guess most of you get the concept and give the right answer as well. So it will be commencing cardiac compression and ventilation at a ratio of 3:2. This is the correct option. Okay, there's another scenario we have. 60-year-old male is brought to the hospital by ambulance following an episode of syncope at home. He develops severe crushing retrosternal chest pain radiating to his left arm, profuse sweating and vomiting shortly after lunch. He presented a syncopal episode as he tried to call his wife for help. She immediately called 000 and on arrival to the ED, his vitals are 80/50, heart rate is 130 regular, saturation will be 91 on 15-liter oxygen, respiratory rate will be 24. He looks unwell, gray, sweaty, and dysphonic. Heart sounds are normal with no normal. Chest X-ray are unremarkable. ECGs are shown. What will be the diagnosis? So let me give you the ECG as well. Once you see the ECG, I will give you the options as well. So these are the options. Okay, so most of you are correct. It's anterior septal lead MI, and this is the correct option. You can also even identify from the symptom as well. But remember this, I make it as simple and I just put the myocardial infarction. They will not do this. They will just put that ST elevation MI, inferior wall MI, lateral wall MI, and like this. So remember this thing that the question will not be easy like this. I just give you for the sake of practice. They will can also give you inferior wall, lateral wall, anterior septal wall, and they'll ask you that what are the findings. That's why I just said that you just focus on your ECG. Don't focus on the options because most of the time symptoms can be same. Some, for example, if what the scenario I have given, if I say that this person have a heart rate of 130 and irregular pulse, so that will be the change. That will be go for the more favor in AFib. So not along with the symptoms, always see the ECG as well. Okay, so for the first step in the plan for a patient diagnosed with asthma, acute pulmonary edema, acute anaphylaxis, myocardial infarction, cardiac arrest, and collapse, go for the oxygen, 8 to 10 liter per minute. Always start with the oxygen. because they will ask you the scenario like this, that a patient came to you in the ED. He is like initial or BLS the resuscitation is achieved. Now you are the doctor over there. What you will do first? So you have to attach the oxygen because already BLS will be achieved. Now he is with you on the ED. So you have to go for the attaching the oxygen. Now they will ask you what will be the initial step, or they will sometime ask you from the question. They just change the wordings. Like what will be the best step? So the best step will be to attach the oxygen. Okay, the major trauma will be we consider those who is having these things: death after injury, admission to an ICU for more than 24 hours, requiring a period of mechanical ventilation, serious injury to 2 or more body symptoms, and injury severity score over 12, or urgent surgery for intracranial, intrathoracic, intra-abdominal injury, or for fixation of pelvic or spinal fractures. This will be the score. Just remember it when you will say that it will be the serious one, and when it is critical one, and when it will be the survivable one. So for the minor, we say 1 to 8. For the moderate, we say 9 to 15. For the serious, we say 16 to 24. Severe will be 25 to 49. Critical will be 50 to 74. Okay, now next will be the very important and AMC's favorite question, indications for imaging, and that question will always come in the exam, and really it will be tough when it comes to the CT scans. So for the head, CT scan is the preferred method of imaging if available, and should be performed early if the severe to moderate traumatic brain injury, right? One thing more, that if they are giving you a thing that a person is having head injury, and that person will be in a very rural setting, and there will be no facility about the ECG, because most of the time in rural setting there will be no CT scans available. So they will give you in the options what you will do after even first you have to resuscitate the patient. What you will do? Always try to find that you have to send the patient ambulatory to the tertiary care, because most of the time people put that CT scan. In rural settings, there will be no CT scan facilities. Sometime they will put that, say, in rural setting there will be no availability of CT scan. You have to cover the topics in for the AMC like this, that you have the knowledge about the aboriginals, you have to knowledge about the rural areas, you have to knowledge about the what facilities are available for the tertiary care, what facilities are not available at the rural areas, because you cannot even give the TPA if someone will come you with these symptoms. You have to send ambulatory to the tertiary care hospital. So make sure before the imaging what they are asking, from which point of view they are asking, and if they have the facility available over there, so go for the CT scan. Because after ruling out the CT scan, we can get the image like patient is having ischemic stroke or having hemorrhagic stroke, or it is either from the embolus or either from the thrombosis, what will going on, right? So if appear that patient will require transfer to major traumatic services, the decision as to whether to conduct a CT prior to retrieval must be considered. Any CT scan that are performed prior to transfer to MTs must be sent with the patient. Any critical trauma patient must be very carefully monitored and attended while in the CT scanner. Traumatic brain injury is important topic, and if one question from this topic, if almost every month will come from this topic, right? So remember this, when there is acquired brain injury, we will divide into non-traumatic brain injury and traumatic brain injury. In non-traumatic, that will be the anoxia, infections, stroke, tumors, and metabolic disorders. In traumatic brain injury, we will divide further into the open brain traumatic injury and the closed brain traumatic injury. In the open brain traumatic injury, we further divided into the assaults, falls. Remember this thing, the question will be asked from the open brain injury among the falls for the elderly. Falls for elderly, falls for the children as well, accidents, bruises, and surgeries. For the closed traumatic brain injury, there will be assaults, there will be falls, and there will be accidents, and there will be the abuse. In close traumatic injury, falls from the old patient that will be fell down on the washroom, and after some time they will come with a subarachnoid hemorrhage. So that questions will be very important. You have to remember that how you will approach the patient, how you will do the CT scan, and you have to all you can get when you remember the causes, and when you remember what will come in the close injuries, what will come in the non-traumatic injuries, then you will go for the further investigation. So these are the very important side. Definitive indications for CT scans are GCS under 9 after resuscitation. Neurological deterioration such as 2 or more points on the GCS or hemiparesis, drowsiness and confusion, persistent headache and vomiting, focal neurological sign like pupil inequality, changes in reactive such as dilated pupils and unreactive on one side, hemiparesis involving the limb on one side, skull fracture known or suspected, penetrating injury known or suspected, age over 50 years, traumatic any injury, increased risk of injury in the elderly, post-operative assessment such as emergency burr hole evacuation, seizures, other risk factors such as chronic liver disease or the use of anticoagulants, because prolonged use of anticoagulant can also cause hemorrhagic stroke as well. So these are the definitive indications for the CT. And trust me, they will give you one scenario for this, that a 30-year-old person who is having skull fracture, known or suspected, came to you to the ED after even initially resuscitated. What you will do next? So for that patient, you have to send the patient for the CT scan. And sometimes say that a 4-year-old boy was playing in the ground and he was fell down and his head is just hit on the swing. And after that, he will remain unconscious for a 1 to 3 minutes. And after that, he will be okay and came to you to the ED. What you will do? So for that child who is now okay and playing with the toys or something, as the child is 2 to 3 year old, we cannot expose directly to the CT scan because one CT scan is equal to 100 X-rays. So for that child, we have to observe because that child is mildly unconscious for that 2 to 3 period and now is playing, feeding, and doing everything. You cannot send the patient to the home. You have to send the patient for the observation. And after observation, you can send home with the knowledge. It will give in the BCQ that you have to send the patient with the knowledge that if something persistent pain, vomiting, something happens, you have to come or go to the ED back again. So these type of BCQs will come in the exam. They will not straight away ask you the CT scan indications, but they will give you the scenarios and you have to pick the things from the scenarios. Okay, this is the adult with a blunt headache injury. This is a very good chart that when you will go for the head CT scan and when you will go for the observation, because we will divide into the high risk head injuries, minor head injuries, and triple head injuries. This chart is very, very important. You have to do it. As I told you that if there is a high risk injuries like GCS is less than 13, post-traumatic seizures, unstable vital signs with major trauma or focal neurological deficit, you have to go for right away to the CT scan. But if there is a mild head injury, like patient with a history of loss of consciousness and amnesia or disoriented and a GCS of having 13 or greater when examined, what you will do for that patient, you have to even either of the medium risk, you have to remember that which category it is for the high risk or minor risk. For this, you have to go for the close observation. And in the close observation, if there is some deterioration, you will go for the head CT scan. So this chart is important. When you will go for the in high injuries, you will go for the CT scan. When you have to wait for the observation, when you have to repeat the CT scan, this chart is very help you in cracking the MCQs. Okay, for the spine, all major trauma patients suspected of having a cervical spine injury should be evaluated using the Nexus criteria. Nexus criteria provide a decision tool for use in the assessment of conscious patient to indicate those at very low risk of cervical spine injuries following blunt trauma who may not even needing radiological imaging. patient are considered to be at very extremely low risk of cervical spine injury if all of the following criteria are fulfilled. No midline cervical spine tenderness, no focal neurological deficit, no evidence of intoxication, no painful distracting injury, no LOC. If these signs are not available, don't go for just for the sake of that patient having cervical injury, don't go for the CT scan, right? So you have to fulfill the criteria and then you will have to go for treat the patient SOS. If all of the above criteria are satisfied, clinical examination may then proceed. Because if one of the criteria is not proceeding or a patient is not moving the neck, you have to give the first cervical spine collar because you have to stabilize the cervical spine. If there is no evidence of any bruising, deformity, or tenderness on examination, and if a full range of active movement can be performed without pain, including 45-degree rotation to the left and right, the cervical spine can be clear without radiological imaging, and the collar can be removed. Never go for without even doing, because most of the question in the exam, it will be like cervical spine will be hit and they will give you these all the indication that there is no cervical injury, but everyone will in the exam will put that MRI of the cervical spine, CT scan of the cervical spine. No, if the everything is on the examination is correct, you cannot even go for the radiological imaging. Should the patient exhibit any of the critical, however, clinical examination is unreliable and radiological assessment of the cervical spine is advised, but plain X-ray may provide initial information on cervical injury, however, are not used to clear the trauma patient of injury. The patient should care for a possible cervical vertebral injury. If there will be a sign, the patient met a nexus criteria, then you have to go for start with the initial one. Not you can go for directly for the MRI, right? If they are asking you for the best or they will asking you the choice of investigation, then you will go for it. But most of the time in the question, they will ask you the next investigation or the initial investigation. So your whole scenario will be the change. A CT scan must be undertaken if the nexus criteria for cervical spine clearance has not been met or the patient is unconscious. Where facilities do not have CT imaging, then consultation with AVR and the MTs regarding retrieval and transfer should be taken. As I told you that most of the rural settings, those having a small medical centers don't have the CT scan. So you have to transfer the patient from the air ambulatory services. X-ray imaging of the cervical spine is not suitable to clear the neck of the trauma patients. A Philadelphia collar should be applied within 6 hours so as to prevent any pressure injury and aid in the patient comfort. For example, you have suspected or nexus criteria is met for a patient having a neck injury or cervical injury and you don't have the facility for the CT scan or something, at least apply the collar. Before transferring the patient, you have to apply the collar for the patient. So the neck is stabilized and that patient will be transferred safely, and after that, the CT scan will be happened. So this is the nexus criteria. National Emergency X-ray Radiology Utilization Studies, that will be the full form, meet all low-risk criteria. That will be no posterior midline swelling, no evidence of intoxication, a normal level of alertness, no focal neurological deficit, no painful distracting injuries. If yes, there is no radiology will be taken. If no, you have to go for the radiological investigation. Okay, for the chest X-rays, a mobile chest X-ray should be performed in the resuscitation bay at the earliest opportunity. Finding on a chest X-ray include pneumothorax, which is difficult to see on a supine position, pneumomediastinum, airspace opacities resulting from pulmonary contusions, and hemothorax. Repeat X-ray should be undertaken after each intervention, such as insertion of a chest tube and intubation. Mechanical ventilation predisposes the patient to better trauma and pneumothorax. So these are the indication for the chest X-rays. Okay, FAST. When you are cracking the general surgery questions, you will see there are a lot of questions from the FAST, because any abdominal injuries, you have to go for the FAST. When you say that a patient came to you having a pulling in the abdomen, you feel that abdomen is very hard or something, or patient is having RTAs, you will see a lot of questions from FAST come in the exam from the general surgery point of view as well. So conventional echocardiography has been long used to image the heart, the pericardial space, and the ascending aorta because ultrasonography is unique in being portable, rapid, non-invasive, and is particularly suited to the trauma setting and offer immediate feedback that may be incorporated into the management for the patient. Ultrasonography is operator dependent and may cause some aortic injuries to be missed. Again, for the CT scan, patients with severe traumas are more even difficult to scan with CT. Patients with severe traumas are more difficult to scan with CT because of resuscitation equipments. CT is an excellent modality, but patients are required to recess contrast agent and may be transported from the protected resuscitation area to the radiological suite. There will be CT scanning is difficult to perform in hemodynamically unstable patients. So these are the contraindications basically, and where you cannot even perform the CT scan, right? In the stable patient, further CT imaging can be obtained to identify aortic injuries like CT angiogram. CT scans also demonstrate injuries to the lung, pleura, mediastinum, and chest wall better than plain radiographs do. Many serious thoracic injuries may be overlooked on initial chest radiographies. These include tracheobronchial tears, diaphragmatic rupture, esophageal tears, thoracic spine injuries, chest wall and seat pal injuries, lung contusion, cardiac contusion, pneumothorax, hemothorax, and chest tube complications. MRI. MRI in the acute setting is predominantly used to evaluate spinal cord, discal ligamentous injuries, and an epidural hematoma. Just mark it down on your slide when you are solving the question from the spine or discal ligamentous injuries. You have to remember that which investigation should be used. Because sometime in the question they say there's a bamboo spine. Oh, we will go for the CT scan. No, don't do this, guys. Just remember the indication, what will be used for which thing they are using. Why they are using CT scans when they are using MRIs, because in the question there are a lot of, you will see in the past papers when you are practicing the questions, there's a lot of question from investigation. There's a few questions from the diagnosis, but most of the question from investigations, because they have to, like AMC systems are trying to make sure that either you are a safe doctor to practice in their country, that if the patient came to the ED, so what you will do? Before diagnosing, you have to send for the investigation. So for those purpose, you have to remember that for which investigation you have to send the patient. So a lot of the question in AMC is regarding the investigation. So it is being more widely utilized for prognostic for the brain traumatic injuries. MRI with breath hold equestration permits good visualization of diaphragmatic abnormalities, but this technique cannot be performed in emergency situation. MRI is also expensive and it not universally available in emergency department. So you remember the good things and you will also remember the where the MRIs are not available. So according, if you know this thing, you will answer the question correctly. For the abdomen, in the trauma patient with abdomen pain, a FARS should be performed early in the primary survey. This is non-invasive procedure is required to perform and can be completed in the ED. Remember this thing, if a patient came to you with an abdominal injury or traumatic injuries and came to you in the office setting, remember this thing that it cannot be possible to do this. So you have to remember which investigations are available in the office test, which investigations are available at the level of ED. Remember this thing as well. First is used to identify free fluid in the peritoneal cavity, sensitive approaching 96% in detecting greater than 800 ml blood, involved directly the ultrasound probe in 4 main regions, subxiphoid to identify fluid in the pericardial space and to assess swelling and contractility, right upper quadrant, liver, kidney, diaphragm, including Morin's pouch, left upper quadrant, diaphragm, spleen, and kidney. Suprapubic view, we will see the bladder. Positive fast result warrant future investigation and management in accordance with the patient's clinical status. For the X-rays, AP pelvis should be completed in the ED to confirm the presence of a pelvic fracture. Again, one thing they will give you in the question, this question will come, you will see in the past paper that a 49-year-old male who was who was trying to put the clothes in the rope and he just fell down from that thing, and they are come to the ED with a lots of blood loss. Pressures are 90-50. What you will do? After even initial resuscitation is giving, hydration is attached, IVs is maintained, what you will do? Already mentioned that there is 800 ml blood loss. So you will suspect a pelvic fracture. You will go for the X-ray for the pelvic fracture. This is the foremost and very important step. Okay, next is that if the patient has a pelvic binder in place, then an AP pelvic radiograph will be performed with the binder on and off. If they say that they will stabilize the pelvic with a binder, so how you can go for the X-ray? You have to do is the on and off thing. This is because pelvic fracture can be missed if they are completely reduced by the binder. Pelvic binder should only be released at a site where the trigger of further bleeding can be managed. There is no role for performing abdominal X-ray beside assessment of ingested foreign body and penetrating trauma with a foreign body or weapon inside you. You cannot go for the abdominal X-ray if there is no indication. Like if there is any indication, like for example, a patient put a watch or eat a safety pin or something, then you will go for the abdominal X-ray. Or there is, you can suspect that a patient cannot even poop and cannot even pass a fluorescence since 8 days. Now you can go for see the obstruction, you will go for the abdominal X-ray. CT abdomen and pelvis must be performed with IV contrast, and oral contrast is no IV contrast and oral contrast is no longer used. Is the modality of choice in assessing hollow and solid visceral injuries, vascular injuries, spinal and bony pelvic injuries, hemoperitoneum and pneumoperitoneum, and allow specific injuries to be graded. In the hemodynamically stable patient with suspected intra-abdominal injury, the key decision is whether the patient requires CT scanning or a period of observation. It is the diagnostic modality of choice in the stable patients. Remember this thing, the question in the exam will be asked from the 3 ways. They will ask you what will be the next step in the investigation, what will be the initial step in the investigation, what will be the investigation of choice in this investigation of choice, and sometimes they ask what will be the choice of investigation in this patient of trauma. So there are 4 categories the patient will ask. Don't go for it that CT scan is the modality of choice if the patient is having 90-60 BP. No, we cannot even do this for the hemodynamically unstable patient. For this, you have to remember it and you have to read the question carefully what they are asking. Contrast extravision found on CT scan is a sign of active bleed and may require interventional radiology services if available. It is also a strong predictor of failure of non-operative management. Hollow viscous, diaphragmatic, and pancreatic injuries are frequently missed on initial scanning. Isolated intraperitoneal fluid finding on CT scan should raise a high suspicion of hollow organ injury. Okay, for the pediatric considerations, for all the pediatric trauma patients, Piper is the first point of call to indicate retrieval and transfer for an advice. Piper will coordinate connection to the pediatric trauma line and retrieval services as required. This is the most hospital will perform some pediatric imaging, particularly in the rural setting. However, the majority of imaging patients are likely to be adult. Imaging in the pediatric population should be tailored so that required information is obtained with the fewest images and the least amount of radiation. As I told you that for giving the exam in 2-year-old boy who just has hit her head on the swing and now came to you, he just get unconscious for the 2 or last 3 minutes and now he's very perfectly fine, eating and feeding and doing everything. You cannot go for the CT scan directly. You will send the patient for observation. Children are more sensitive to radiation exposure than adults, especially related to the thyroid, breast tissue, and gonads. There is a much longer life expectancy over which to express the radiation-induced damage to gene, with girls being slightly and more sensitive than boys. Radiography exposed children to relatively low dose of ionizing radiation, while CT scan exposes them to the greatest. All medical profession must work towards the principle of as low as reasonably achievable regarding radiation dose while utilizing medical imaging, especially when it comes to the children. So there will be the trauma imaging, 3 standard X-ray that should be considered routinely in major trauma RB, lateral cervical spine, chest, and pelvis. The desire to protect a child's reproductive organs should not outweigh the risk of significant morbidity from a missed pelvic injury. Any abdominal, lower abdomen, lower limb, spinal trauma, all true multi-trauma patient have to go for this. All intubated patient, or if the patient is difficult to assay, they must have a plain pelvic radiograph. Always safer to do the radiograph if unsure. These X-rays are basic tests for major injuries. Remember that initial investigation, basic investigation, next investigation. For this, you have to be careful with the words. Full monitoring should be continued while obtaining the X-ray. Ideally, these are done in the resuscitation room while the child is supervised by the emergency staff. For the FAST, evidence suggests that there's a little value in pediatric due to the risk of false reassurance, particularly when conducted by an inexperienced clinician. It may be useful only structurally adult adolescent. The presence of free fluid in the abdomen on FAST does not mandate laparotomy. The absence of free fluid on the FAST does not rule out a significant intra-abdominal bleeding, therefore limiting its application. So FAST is basically not as much as more potent for children as compared to the adults. EFAST is extended fast scanning in children is helpful in diagnosing acute hemo or pneumothorax and hemopericardium when used by a skilled clinician. This is for we are talking about the pediatric portion. Further imaging should only be taken place after discussion with Piper. CT scan can be a life-saving tool for diagnosing injury in children, and its use is steadily increasing. Despite this, one of the major disadvantages is the inevitable radiation exposure. The risk of developing a radiation-related cancer may be several times higher for a younger children compared on an adult. The benefit of a properly performed and clinically justified CT scan must always outweigh the risk for an individual child. Okay, now this is the important thing, transfer. The patient's transfer to a definitive center of care should not be delayed to await further imaging. If imaging has been completed prior to transferring the patient, then ensure series of film accompanying the patient so that repeating imaging is not performed, thereby exposing the patient to unnecessary radiation exposure and a delay in diagnosis. These are the guidelines for acute indication of imaging in peds. Okay, now causes of unconsciousness. Combination of different causes may be present in an unconscious victim. For example, head injury under the influence of alcohol. So the management of coma should be, tips are hypotensive patient that will be bleeding. Always suspect cervical injury, tachypnea, and inadequate oxygenation, not central nerve damage. Unknown unconscious patient, always go for the suspected opioid overdose. These are the 4 things the scenarios will be asked for the ED portion in the exam. Do not allow the person who accompanies to leave without relevant details. Record the degree of unconsciousness as a baseline to determine improvement or deterioration. Always consider hypoglycemia or opioid overdose as a first possible diagnosis in an unknown patient. For example, syncope, postural hypertension, concussion, CV. They will give you a scenario. 33-year-old homeless person came to the ED via ambulance and is unconscious. So what you will be suspect? Always suspect will be the hypoglycemic or opioid overdose. For the homeless person, opioid overdose will be the first possible diagnosis in an unknown patient and who is also the homeless. Principle of treatment, unconscious principles of unknown case, treatment will be the keep patient alive, get history from witness, examine patient, take blood sample, CT scan if required, and give coma cocktail. That will be the short form. Hmm. This is the short form. Always they start with the thiamine, oxygen, naloxone, fluminazole, and glucose. Alcohol intoxication. Alcohol having this thiamine, oxygen for normal patient, naloxone for opioid overdose, fluminazole for the benzodiazepine overdose, glucose for hypoglycemic patient. This is the principle of treatment. Naloxone, opioid antagonist, opioid overdose, constructed people in hypoventilation. If no response to initial dose, intubate, then second dose. For unknown opioid overdose patients, 0.4 milligram IV every 3 minutes if necessary. Fluminazole that will be given for the benzodiazepine overdose. Initial dose will be 0.2 milligram IV, then 0.3 till 0.5 milligram bolus every 3 to 5 minutes until the recovery. This will be the pre-hospital management trauma triage, which I will explain you in the start as well. This slide is important for the early trauma care, that what you have to do, for which thing you have to do. These are the key points for the primary survey. These are the key points for the fluid resuscitation, for the prevent of heat loss, also for the life-threatening injuries, what you will do, how you will manage the patient access for the patient. This is for the intermediate hospital major trauma settings. These slides will be given to you, so you can even see what are the approaches and flowchart for the intermediate, what are for the minor, and what are for the high risk. The scoring are also giving. These are from all the major resources from the Victorian sites, from the RCGP guidelines. So these are very important. This is for the preparation of retrieval, that will be the airway, breathing, circulation, and documentation. This chart is for the deteriorating trauma patients, how you will approach the deteriorating trauma patients. This chart for the traumatic brain injury, as I told you in the start, traumatic brain injury is an important question, and that one question must be come in the exam. This chart is taken from the spinal trauma. And for this chart, and this was from the anticoagulants chart, when you will follow for the period of long time, the anticoagulants even cause the trauma and cause the hemorrhage as well. So you have to even see the charts, and from the charts you can go for the management. Okay. Initial management of this chart is very important. As I told you that lots of charts is from the initial settings, like these all charts are enough. If you do these charts, you can even easily crack the questions from the ED. Like for the pediatrics, from the obs gynae portion, from the any type of cervical injury, if you learn these charts and you remember the flow charts, you can easily even go for the questions. Just remember these flowcharts, and for the initial management, all initial management are same, like airway, breathing, circulation. The thing come which is different is for the fluid resuscitation, pain management, managing the wound, circumferential burn. When you are when the okay, Dr. Azhar, when the slide will be provided to you, the charts will be clear. Don't worry about it. Okay, one and more important thing about that is in burn management, the most commonly asked question will be the how the surface area you will be can consider for the major traumatic injury. Like most of the people will mark that greater than 70% will be the severe total body surface area for adult. No, it will be only 20% greater than total body surface area consider a major trauma for the adults, and greater than 10% total body surface area consider the major trauma for the children's. Now it comes to the fluid resuscitation. Then when it is greater than TBS, how you can give the fluid? What will be the next investigation? So always find in the option that you have to use Parkland formula for this. For pain management, you have to give 2 to 5 milligram morphine and repeat it every 5 minute gram. And for the pediatric, there will be dose for the 0.1 milligram per kg. And for the management of the wound, you have to go for the rule of 9. And then clean and cover the wound. For the circumferential burn, you have to elevate the limb where circumferential burn present, assess the perfusion distal to burn, capillary refill, pulsal, warmth, and color. This chart is very important because sometimes they will say that airway is secure, oxygen is maintained, IVSS is done. What you will do the next? So for this, find in the option that fluid resuscitation have to be commenced. The reason I'm putting the flow charts, they will ask you the question from these flow charts. And you have to answer for this according to the asking in the exam. Either they're asking for the initial investigation, either they are asking for the next or best investigation.
Hi, Dr. Azhar. Just to let you know that you can zoom in your screen as well if you want to read the chart from the session right now. So you just have to zoom in your screen and you will see all the content that is mentioned in the chart.
Okay. So in an adult not breathing normally, what is the first step in management? Okay, when the PDF will be provided, when the recording will be provided, so these charts will be very clear. Don't worry about the charts because I have to put on the slides, so I need to be very maximize it, so it will be blurred. But don't worry about it. Yes, most of the guys are correct about this question. So we will move for the next 43-year-old male admitted with central crushing chest pain radiating to jaw. Pulse is 69, BP is 110/70, ECG normal. What is the most likely diagnosis? Anyone? I guess this is the easiest question. Why people are giving the answer B, E, and D? There is a very variability in the question. This is the easiest one. Yes, the answer is acute MI. For those who are asking, giving the answers about the pulmonary embolism, for the pulmonary embolism, symptoms can be like this. However, it's rare, typically present with having pleuritic chest pain, not with the crushing chest pain, right? Shortness of breath, hemoptysis, sinus tachycardia, calf pain, ankle swelling, DVT, and specific risk factor for DVT are also present for pulmonary embolism. But I told you that in a patient being relatively young, the history of central crushing chest pain radiating to the jaw is typically MI. The ECG may initially be normal in some patient as well. So from the symptoms, from the thing, you have to see this thing. In the initial cases, ECG can be normal. So go for the MI. For the asking pulmonary embolism, there will be a risk factor. There also swelling. For pleuritic chest pain, there will be pain on inspection. They say that the pain is on the movement. For the GRD, there will be retrosternal pain, sharp epigastric pain, bursting on the lying down, and bursting with the before the meal. So these are the clue points that you have to remember it. For the acute coronary syndrome, ST elevation MI plus troponin plus positive, right? For non-ST elevation MI, there will be no ST elevation, but troponin is positive. For the unstable angina, no ST elevation and troponin is negative. So the question can ask in this way as well. They will just give you a very simple investigation from the symptoms. So you have to go for it. I guess this question I get variable answers. Just remember this chart and remember the symptoms. You will crack the question. Which one of the following is not a side effect of amiodarone? So the answer will be the bronchoconstriction, because bronchoconstriction can occur with adenosine and beta blockers. These are the contraindications for the bronchoconstriction. We cannot even give asthma patient adenosine and beta blocker. Remember this thing, because questions can come in the exam. They will give you SVT, they will give the scenario, and they will also mention in the exam in the end that patient is asthmatic. What you will do? By seeing everything that patient is having STVT, they will just give the adenosine without even seeing that patient is asthmatic. You cannot even give adenosine to the asthmatic patient. So these are the side effects. These all are the side effects: hyperthyroidism, pulmonary fibrosis, prolonged QT interval, torsive points, skin pigmentation, and eye problem and GI problem. These all are the long list of side effects. Okay, 23-year-old male has been suffering of low back pain and early morning stiffness for at least 1 hour every morning for the last few months, which improve with exercise. Which one of the following cardiac condition is in the patient most likely to suffer in the future? Before answering the question, always remember the age of the patient. See how the AMC can ask the question. They are not asking you directly the diagnosis. They hide the diagnosis, and from the diagnosis, the what will be the extra articular complication, they are asking you in this way. So I will make the simplest for you guys. Now you can answer better. Yes, very correct. This is a condition, but it basically is a ankylosing spondylitis. Patient with this condition have numerous extraarticular complication, and aortic insufficiency is one such complication observed in these patients. So, ankylosing spondylitis is a seronegative, that is rheumatoid factor negative inflammatory autoimmune arthropathy, which is typically associated with the following features: more common in male, age of onset 20 to 40, associated with HLA B27 allele, lower back pain, early morning stiffness and symptom relief upon exercise, bamboo spine, may be associated with inflammatory eye disease, that will be the anterior uveitis, may be associated with cardiac disease, that will be aortic regurgitation or insufficiency, may lead to congestive heart failure and heart block. Investigation will be ESR elevated. Shower test and treatment will be conservative physiotherapy, exercise, medically will be NSAIDs and immunosuppressive medication. So this question can also be asked in a way of anterior uveitis as well, that a patient who is 23-year-old now came to you having red eye, pupil is constructed, having watering. So what will be the cause? So that will be the anterior uveitis due to ankylosing spondylitis. This is the way that AMC asks the questions. Okay, which one of the following is not a feature of inosine murmur? I guess most of the people get confused over here. So there's a explanation of that. Inosine murmurs are murmurs with no structural abnormality. Features include cystolic, soft grade, grade 1 or 2. Never purely diastolic. If diastolic invariably associated with a cystolic murmur, does not radiate. Never accompanied by a thrill. Changes with posture, typically heard at the left sternal edge or left clavicular region. Often heard in febrile child due to hyperdynamic circulation. Okay, this is the hint I gave you for you guys. That question with answers that contain only, never, always, invariable, usually contain incorrect options and vice versa. This is the hint I put you, so remember this thing. Okay, which part of the following is not part of the acute treatment of ACS, like acute coronary syndrome, 300 milligram aspirin, 300 milligram clopidogrel, enoxaparin, morphine, and oxygen therapy? Which is not the part. They are not asking the part, not the part of ACS. I just give you the hint as well in the below. I guess most of the people are right. There's no role of enoxaparin in ACS, right? Another question is persistent ST elevation despite percutaneous coronary intervention is a ECG finding seen in condition. Like they didn't give you the ECG, they give you the finding of ECG, and now they're asking that what's the condition? Few people are giving correct answer, but most of the people are confused because there's no ECG giving. So the question in the exam can ask you in this way as well. You have to remember the ECG findings as well because sometimes they didn't give the ECG. So for the answer, it will be a left ventricular aneurysm should be suspected in a patient with prolonged ST elevation demonstrated on a ECG. It is a complication following a MI, although there is a settling or ST elevation in pericarditis. Those who are giving the pericarditis A are wrong. This is subsequently preceded by pseudotransition, T-wave inversion, and then normalization. Sometimes they not give you the ECG, they will give you directly the findings. So remember this thing. In ECG, they in the question they are saying persisting ST elevation despite percutaneous coronary intervention. So that will be the left ventricular aneurysm. It will be prolonged ST elevation. For pericarditis, there will be the settling or ST elevation, right? If prolonged ST elevation on ECG, that will be go for the left ventricular aneurysm. And also they are mentioning in the question that despite percutaneous coronary intervention as well. And they're subsequently preceded by pseudotransition, T-wave inversion, and then normalization. So you can have to be very good in ECG because sometimes they will give you the ECG and sometimes they will ask you in the scenario. Okay, which one of the following is not an initial pharmacological therapy used in a patient presenting with non-ST elevation MI? I guess a few guys are giving the right answer and most of the people are giving the wrong answer as well. So, treatment for non-estimation MI or unstable angina include morphine, nitrate, oxygen therapy, aspirin 300 milligram initially, then 75 milligram, clopidogrel 300 milligram initially, then 75 milligram, and enoxaparin, and even we can also give beta blocker unless there is contraindication like asthma, acute left ventricular failure, right? So patient with ST elevation MI, you'll usually require urgent thrombolysis or primary PCI, so we cannot give heparin. So most of the people, I guess, give the wrong answer. Only few people give the right answer. Another question is like, which of the following does not raise JVP? The right answer was heparin, that we cannot even give in unstable angina. We cannot give IV heparin. So they're asking the not. They are not asking the what will be we have to give. They're asking what will not we have to give. This is the easiest one. Okay, the answer will be in portal hypertension does not causes a raised JVP. Note congestive cardiac failure which itself a cause of raised GVP may lead to hepatomegaly. So portal hypertension does not causes a raised GVP. How many hands are used to compress the chest of a 6-year-old child? Now the question from the ACLS and BLS. Okay, I guess most of the people answer it. So according to the AHA protocol, we use only one hand for children approximately the age from 1 to 8 years old, and two hands for the adult and larger children like for greater than 8 years old. Doctor, I didn't get you which question you just missed. Probably you will get the findings. Sorry, we will get the recording, so you can even see that questions later as well. Don't worry about it. What will be missed, that will not be gone. That will be provided by to you. Just come with the flow and come with this thing, right? So the answer of this question will be the one, because according to HA protocol, one hand for children approximately 1 to 8 years old child and two hands for adult and child greater than 8 years old. Okay, which of the following is not a cause of raised troponin level? I just mentioned it in the previous slide as well. That's what I've mentioned in the previous slide, but still some people are answering it PE and fast AF as well. So it's wrong. It's basically unstable angina. Unstable angina, I told you in the previous slide that it's troponin negative cardiac pathology. ECG changes may be present in the form of ST depression. Any pathology likely to cause MI strain damage will result in troponin rise. A rise troponin in the presence of renal failure should be treated with caution due to reduced renal excretion. Such patients should have further trough measured, and if these are rising, MI injury is confirmed. Other causes include sepsis, trauma, and tachyarrhythmias as well. So the answer will be unstable angina over here. Okay, when compressing the chest of an adult child in pain, what will be the depth of compression? This is the question. There is no specific answer over here because in adult child in pain, the depth will be the different for everything. So I just put this question to remember you guys the ACLS protocol or the BLS things, that this question can be asked from the adult child as well, for the pediatric as well, and for the infant as well. I just put this just to remember it, that this question can be asked from that adult as well, child as well, and parent as well. Remember this, for the adult, at least 2 inches, that will be 5 centimeter. For the child 1 to 8 years, at least 1/3 of the chest cavity depth, that is approximately 2 inches and 5 centimeter. For the infant, that will be 0 to 12 months, at least 1/4 inches of the chest, which is approximately 1.5 inches, 3.8 centimeter. So these are the according to the child, according to the adult, and according to the infant. I put this / for this because these are variable. If that's why I just started with the session with BLS, and for the protocol, that will be, I guess, make you guys boring. But now you see that it is important, because in the exam, the question will be asked from this way. They can ask sometime child, they can ask sometime adult, they can ask sometime about the infant. Okay, and the next will be when a shock is advised on the ED, what you will
Excuse
do?
me, ma'am.
Yes.
For child and adult, both it will be 1/3, right?
Yes, I just said that as the AHA protocol, as the adult for at least 2 inches, that will be the 5 centimeter, but not more than 6 centimeter, right? For the child 1 to 8 years old, that will be at least 1/3 of the chest cavity. That will be approximately 2 inches and 5 centimeter. And for the infants, you will go for the 0 to 12 month. That will be 1/4 of the chest cavity depth. That will be approximately 3.8 centimeter. I will put it in the chat box so you guys can copy it. I just put it in the chat box. I guess most of the people can get from there. Okay, the question will be, when a shock is advised on the ED, what you should do? Okay. I guess most of the people are asking for the check pulse. As I told you that when the shock is advised on the ED, you have to clear the patient and then press the shock button. That's why I told you that this flow chart for the BLS and ALS is very important. When the shock is advised from the ED machine, you have to clear the patient, like you have to clear the field, and then you have to press the shock button. Now, in the start, I guess where everyone was taking it very light, and I told you that the question will be asked from the flow charts. Okay, how long after ED shock do you commence CPR? Dr. Mahesh, you will get the whole guidance, just text on that page and you will get whole information about it. Okay, I guess everyone are right over here. Immediately, as I told you that you can only stop CPR in 2 or 3 conditions. First is when you are assessing the pulse, and another is when you are giving the shock. Ratio of compression rate per minute for one person will be 30:2, and the rate will be from the 100 and 120. Always remember that. Compression ratio will be 30:2 breath, and the compression rate will be the 100 and 120. Okay, if CPR is began, perform, and a ED arrives you, what you should be do? Okay, so here is you have to continue the CPR, and AD operator should attach electrodes and assess heart rhythm. Because you know AD operator is a machine. He will once you connected the AD, it will give you the all the things and commands by itself because it's a machine. You have to continue the CPR while the person is placing the electrode. You have to continue it while the rhythm is assessing. Once the rhythm is assessing, the machine will give you the further command that please shock it advice, clear the field. So for this, you have to clear the field, but continue CPR and AD operator should attach electrodes and assess heart rhythm. This will be the right answer over here. Okay, mechanical vehicle trauma patient came to you in the AED. Rib fracture on chest X-ray, AO knuckle not seen. Suspected cardiac tamponade, what will be the most appropriate next step in the management? I guess I put the answer on the same page. We will do the periocardiocentesis because it's the diagnosis and the treatment as well. This is a medical emergency and echo is the only diagnosis over there. Okay, you are called to evaluate a dyslexic patient in the ED. The patient has states a stab wound on right hemithorax and that a chest drain was placed with under seal water seals drainage. On physical examination, there is diminished expansion of the right chest and the chest tube seems to be blocked by a blood clot. What is the immediate treatment to be done? Those doctors who are giving the answer of milk the chest tube, how you can milk the chest tube over there? I want to know. Okay. So underwater seal drainage is considered management for pneumothorax, not hemothorax. This patient has a pneumothorax, drain hemothorax, FNAC aspiration for a small volume, and also diagnosis type for the bleed. Or in the case of a large pneumothorax, insert a high inferior tube for air plus a low posterior tube for blood. Answer will be change the tube. You have to place another tube. You have to change the tube. Because we cannot milk the tube because that tube had already a clot, right? So you are working. No, you cannot milking for it. You cannot do over there because it's an emergency process, right? If you take a time for the milking, you will lose your patient. You are working as the AED registrar at a rural hospital. Hospital protocol state that all critical patients should be airlifted to the tertiary hospital located 650 km away for first aid and stabilization. You have an MBA patient diagnosed with multiple bilateral retraction and small hemoperitoneum on left hemothorax that were drain and ED. The patient vitals are BP is this, rate is this, saturation is normal, oxygen mask, temperature is 37.2. He has IV line with normosaline and morphine drip for the pain. You need now you need to prepare the patient for transportation to tertiary hospital. What is the appropriate management? What you will do? Doctor, milking is basically a manual technique we use for the removal of air or fluid blockage in the tubing, right? We can like put on the gloves, identify the blockage or king, and then place hand or close to the blockage. Another hand further down the tube and gently squeeze the tube with your hand and continue squeezing and sliding your hand just because the tube is blocked, right? We will do it when for removal of air bubbles or kinking or fluid or for the small blood clots, but for not the definitive treatment. We will have to replace the tube or we have to change the tube or place another tube, right? Okay, this is I guess a bit tricky question. And most of the people, I guess, answer the right. Only few people give the bit wrong answer. So for this patient, chest tube is the answer. First step in the management of traumatic pneumothorax is placement of a chest tube. Hemothorax stop bleeding immediately. Simply needle drainage is all that required. Chest tube caliber should be 36 French to drain without clot. If a clot obstruct the tube, replace immediately to avoid tension pneumothorax. That's why we are not even milking the tube, right? If a clot is obstruct the tube, replace immediately to avoid tension pneumothorax. Chest drain for simply pneumothorax place anteriorly and underwater. Chest drains for simple hemothorax place posteriorly. If there is pneumothorax, flail chest patient have multiple rift fracture with PPV, drain should be placed anteriorly to avoid tension pneumothorax or obstructing the chest tube. This is very, very important. Trust me, when you go for the chest portion or lung portion, this question will become in the exam. And these are point taking questions. Like these are main ED questions. If you are correcting it, you will get the more point. As AMC have the logic, the more difficult question you corrected, the more points you will get it. Okay, tracheotomy required in under 10% of thoracic trauma patients. Hemorrhage is from injury to lung parenchyma. Generally, it stops bleeding without intervention. Blood from drainage will be cloudy and dark. That is venous. No thoracotomy is required. penetrating trauma is more likely to be associated with arterial hemorrhage requiring surgery. Thoracotomy is required if there is red blood, that will be arterial. The next patient is a 35-year-old woman who's having penetrating chest trauma on left side. He is increasing SOB, cyanosis, tachycardia, tachypnea. The X-ray show a mediastinum shifted to right side and no tissue, lung tissue on the left side. What is the approximate management over here? I guess most of the people give the right answer over here. That will be shifting of mediastinum. That will be the tension pneumothorax, and the treatment will be the needle trichotomy. Another question will be a 22-year-old indigenous man and brought into the ED by paramedic with open wound to chest after a brawl at a local pub. On examination, vital signs remain stable, but you notice a dullness at left lower lobe of the chest and reduced sounds on left side. In your opinion, what will be the management next? What you guys are suspecting over here? I want to know that everyone is putting step pound, step pound. Are you guys sure it is a pneumothorax? It can be hemothorax. Don't anyone think like that? Yes, Dr. Sashi, you are correct over here. So for these questions, you have to go with the diagnosis first. So now you guys tell me what will be the treatment. Yes. Always go for the, you guys are correct now. They always first make the diagnosis and then you will get the treatment. Okay, 45-year-old female present to ER with mild periodic right-sided chest pain. A chest X-ray revealed a mild, less than 1 centimeter ring of air outside the lung at the apex. What is the correct initial management of this patient? Remember it is a mild, less than 1 centimeter. Okay, I guess most of the people answer correctly. The D is right. The pneumothorax is small. It is likely to resolve with no treatment. We will do simple repeat the chest X-ray after a period of 24 to 48 hours. Aspiration may be successful, but is risky in such a small infusion. So we will observe the patient, repeat the chest X-ray, and will treat accordingly. Now, first step management is partially choking conscious adult. Remember this thing, those who will answer follow the BLS flowchart, this patient is partially choked and conscious. We will start the BLS with the unconscious patient, right? So we will lie a patient on the side, check and clear airway, and give up the 5 back slaps. Or we will do the different maneuver. A patient falls while riding on her horse and suffer from fracture of right humor and a right rib fracture. On chest X-ray, a mild pneumothorax is noted. On examination, saturation is 99% on room air. Respiratory rate is 14 per minute and is hemodynamically stable. She wants to be airlifted to a tertiary hospital to be close to family and friends. What interventions will be needed before transfer can be approved? Okay, most of the people are right over here. The answer will be A. Another question will be during CPR on 72-year-old female, you notice that the chest does not rise effectively even though the breath are completely performed. What is the next step? Yes, we have to check airway is open and clear. This is, I guess most of you are right over here. You are evaluating a 56-year-old mechanical vehicle accident patient. The only positive finding is intense upper abdominal pain. BP is 90/60, pulse is 120, respiratory rate is 19, temperature is 37. What is the immediate next step in the management? Yes, for this patient, you will all go for the fast ultrasound. And if sometimes they will not put the fast word, they will put the ultrasound. So people get confused and they will go for the triple CT scan or laparotomy or laparoscopy and something like that. So never get confused. Fast ultrasound is a type of ultrasound. Just we put the fast word because we are doing in the ED for the patients who are just coming from the RTS. Best posture for a conscious casualty with an abdominal injury. Okay, those answering recovery position, what is that thing? Because we are over here, we are asking for the abdominal injuries, right? For the recovery position, we will do when there's any obstacle, removing any obstacle from the mouth, turning their head on one side, lift their chin up. So with these are the situations we will go for the recovery position, right? Not for the abdominal injuries. Yes, on back with legs flat. Because there's an abdominal injury and you have a fluid over there. You cannot even sit upright. You cannot even bend your legs. You cannot go for the recovery position. We can follow the Fowler's position or recovery position when there is an airways or obstructed related in something like there will be a airway blockage or something obstacle in your mouth. Then we will go for that position. Okay, child Child with abdominal trauma due to MVA, the nurse calls you to tell you that the vital signs are dropping and the pain is increasing. What is the next? Okay. As this question is from the recall, so it is not the full question. It's basically a breaky recall. Two things. One, if they say in the exam you will get a very full and clear picture. Over here, there are two things. If the vitals are dropping and patient is already on vitally stable, like patient is already vitally stabilized and now the vitals are dropping, then you will take the patient for the ultrasound and then allergen laparotomy. But if the patient has came to you with abdominal trauma with MVS setting in the AD, the first step will be the IVSS and expand with normostatin and give more painkillers. So this question you have to see in the exam that what they are asking initially. If they're asking the initially, you have to go for the ABC, airway breathing circulation. For circulation, airway breathing was already maintained on the roadside. And for circulation, you have to give the normostatin and expand painkillers. But if they say that this will be done and the patient is now deteriorating, then you will have to move the patient for the investigation and then for the laparotomy. So for the in the question in the exam, you have to see what they're asking. This is very important. Okay, 18-year-old MVA patient complains of pain on tip of shoulder. On physical examination, something seems okay, except for seatbelt sign on abdomen. The initial blood tests are, as I told you, doctor, we cannot do CT scan on the patient who is vitally unstable. The initial blood tests are normal and nothing is seen on the chest X-ray. What would be the appropriate next step in the management? Remember this thing, there are two things over here. One is this patient is vitally stable because they say that on physical examination everything seems okay except for the seat belt. So this patient is vitally stable. Remember my keyword. This patient is vitally stable. Now you can answer it correctly. Now you guys are right. For vitally stable patient, as a physical examination seems okay. Only the sign for seat belt. For this, initial blood tests are already done, X-ray done. X-ray done means you have already done with the fast ultrasound as well. Now, because everything seems okay, you have to go for the CT scan to exclude interperitoneal hemorrhage. As CT scan is the investigation of choice for the stabilized patients, right? A fast ultrasound, everything will be done in this patient already. But the seems everything okay, nothing for the seatbelt sign. But the seatbelt sign is the indication that there will be much interperitoneal bleed. So for that, we have to go for the CT scan. Okay, which of the following is a surgical emergency? So here all are the surgical emergencies. Another thing that's very important, most commonly missed injury in a bad trauma will be the 90% kids spleen injury and asymptomatic. Remember this thing that missed injury will be in the abdomen will be the spleen. So what is the key that should be considered when dealing with human blood and other body fluids? Okay, this is the answer. C is correct. Consider all human body and body fluids as being potentially infected. So for this purpose, we have to screen for it. Signs to consider a shock. To recognize the shock, what are the signs? Very good. Okay, best method for dealing with amputated part. So we have to seal the amputated part in a plastic bag and place on the top of thin material and ice. What is the best position for a conscious person suffering from shock? Okay, that will be the tenderable position. You have to keep the lying down with their feet elevated 18 to 12 to 18 centimeters above the level of their heart. Keep lying their head and neck in a neutral position, right? How is hepatitis B transmitted? That question will become with a scenario, not they are directly giving you the scenario like how it is transmitted. That's why I'm asking you guys, but they will give you a scenario. There are two people who is 19-year-old having an intermittent sexual activity or something like that. So they will give you a scenario like this. So you have to remember that how hepatitis B is most commonly transmitted and how is hepatitis C is most commonly transmitted. I put in a very short thing, but they will ask you in a scenario form, right? Yes, for the drug abuser, we go for the hepatitis C, and for the sexual activity, go for the hepatitis B. Very right. If a patient vomits or gargling is here as air expires after each inflation, you must immediately do what? Very good. We have to turn the patient on the side, clear airway, and aspirate airway. 24-year-old man is brought in by his mates on physical examination. He has GCs of 10, pinpoint pupil, pulse is 75, BPS is 90, 50, respiratory rate is 8, and you also notice several little tracks on his arm. In your opinion, what is the most likely diagnosis? So here it is. I told you that homeless person, this type of person, we always go for the opioid overdose. That will be the most common over here. If an unconscious person remains on the back, what will be the most likely cause of an airway obstruction? Okay, the answer is tongue, because that's why we said that when the unconscious person, always go for the good airway or put airway, because your tongue can block the airway and person can die. Okay, this is the interesting question. 27-year-old female, BMI 31, present with a 3-day headache, present to a clinic. She has no important personal family history, just OCPs from the age of 24. She refers no other symptom, just headache that doesn't go away with over-the-counter analgesics. She bring you a normal CT scan brain that was ordered by another GP. You've decided to perform a diagnostic lumbar puncture that show the following results. CSF, that will be 42. That's a CSF opening pressure is a lot. Normal is 10 to 20. Macroscopic appearance is clear. Bottle 1 and 3 show RBC and gram staining is negative. MSC show no growth. Glucose is 4.5. Xanthochromia is negative. Except for the CSF opening pressure, everything is normal over here. So what is the most likely diagnosis? Everyone is correct, I guess. The answer over here is benign idiopathic intracranial hypertension or pseudotumor cerebri. The pressure is very high. CT scan was normal, excluding raised IC secondary to an obstructing hydrocephalus. Xanthochromia testing is the sample is negative, providing no evidence of prior bleed into the CSF. The diagnosis of subarachnoid hemorrhage, you have either blood or altered blood in the CSF. The diagnosis is benign intracranial hypertension. Fact is, woman is young, obese woman, vitamin A, contraceptive pills, and is not benign. Untreated, it can produce HA, blindness, blurred vision, and tinnitus as well. Treatment is via mean to reduce CSF pressure either from repeated lumbar puncture or you have to ask for the weight loss or you have to give the diuretics. As I told you, for the hepatitis B, it will be from the sexual activity, and for the hepatitis C, most common will be from the IV drug abusers. Okay. Sign and symptoms of patients suffering overheating and dehydration after ecstasy consumption. The answer over here is raised body temperature, cramps, hot dry skin, headache, dizziness, sudden fatigue, inability to urinate, and fainting. Another will be first line treatment in a tense and panicky patient after taking an unknown recreational drug. What I told you for this, I just give you a mnemonic. Doctor, you cannot even reassure the patient who is already take a unknown recreational drug and tense and panicky. That patient will be die from the choking and from the panic attack, right? So we will go for the tongue, thiamine, oxygen, naloxone, and glucose. This therapy we will go for that. We have to check the hypoglycemia. We have to check for the drug overdose. We have to check for the alcohol intoxication. We have to check for the any breathlessness. So we follow the tongue, right? Okay, if a person is conscious after a CVA, how do you position them? The tongue is thiamine, oxygen, naloxone, and glucose, and also the fluconazole as well. These all are the drugs we have to check for the patient. Okay, for this type of question, I just put this question and with different type of options. The question will not come in the exam, but remember this for the CVAs, we have to go for the head elevation, sideline for the conscious patient. Remember this, sideline positions, the neutral spinal alignment, support or effectively in uncomfortable position, right? I put these option along with that. Just remember the positioning. Don't go for this finding the option from there. I just put the option just trying for you familiar that the question can ask you in this way as well. So for the conscious CV patient, we go for the head elevation and side lying position, right? Which one of the following statement is incorrect regarding surgical emphysema in the chest? So COPD does not cause a surgical emphysema. Surgical emphysema is a medical emergency. This is a clinical finding of air trap within the subcutaneous tissue of the thorax. Common causes include perforated esophagus and iatrogenic causes, right? Another is which one of the following is incorrect regarding management of a patient with a life-threatening asthma? So the answer over here is a laryngeal mask airway is not the most ideal method of ventilating a patient with life-severe threatening asthma, as it is unable to provide the negative pressure requiring to adequately withdraw air from the lungs of these patients with severe lower airway obstruction. So we cannot go for the laryngeal airway mask over here. Okay, 37-year-old IV user is referred by his GP for suspected Bell's palsy. On examination, his inner ear, there are a number of vesicles visible on the eardrum. His cranial nerve examination reveals a weakness of the whole of the left side of the face. What is the most likely diagnosis? Okay, I guess most of you are right over here. It's Ramsden-Hunt syndrome. Okay, what are the DDs you will be suspect in the case of CVS? That will be the syncope, seizures, cerebral traumas, multiple sclerosis, delirium, somatic pain, acute labyrinthitis, migraine, head injuries, right? Okay, we are just on the end of the finishing our questions. 64-year-old male present to a hospital with his first epileptic seizure while sat reading a newspaper at home. Drug history, there was no drug history. Clinical examination reveals this, and this. Neurological examination include cranial nerves and fundoscopy examination all are good. His blood tests show the following. Chest X-ray is ill-defined lesion in the left mid zone. Only finding over here is sodium is less 129. So what is the most likely etiology of his seizures? Guess most of you give the right answer because here is the we are suspecting the malignancy. The most likely there is no clue from the seizure from data provided makes the most likely diagnosis of lung cancer that will cause the SIDH. Most likely small cell carcinoma that causes the hyponatremia. I'll just take a 2-minute break when that's on my side. Okay, so this is a live slide. Is it for the tips for the MCQs? Always consider hypoglycemia or opioid overdose in a young cerebrovascular incidents, basically strokes that we will call CVAs, right? Always consider hypoglycemia or opioid overdose in a young unknown patient. Consider intra-abdominal bleeding first in a patient that has abdominal pain and collapse at toilet. That will be aortic aneurysm rupture. Acute chest pain in MI until proven otherwise. Sudden onset of respiratory distress plus pillar in child will be the acute epiglottitis and also the foreign body as well. Persistent post-traumatic abdominal pain is a rupture intra-abdominal viscous in any patient, especially children. Consider postpartum depression in a patient with undifferentiated illness or not coping with baby. Fertile woman with acute abdominal pain will be ectopic pregnancy. Sinus patient will go for the upper airway obstruction first. Adult plus sudden collapse will be the ventricular fibrillation or arrhythmias. Sudden vascular severe headache will be the subarachnoid hemorrhage. With this, we just ended our session today. Hope you just understand it. It's just for you guys to give the oriented or insight about how they will ask the emergency questions in the exam in the AMC-1 and as well as in the AMC-2, just to see are you guys are safe for their practice to work in Australia. So these are the tips and these are all the BCQs from the past, all the BCQs from the pools. And this is the very important topics. Everything regarding how you get the lecture and how you get the recording, Asma and the organization will told you. And with that thing, we are just ended our lecture. Please, guys, you for the link for the other information, you please message on the MedExpert page or MedExpert WhatsApp, right? Hope to meet you guys in recall sessions or a whole regular course session. For any type of query, just ask for the ASMA and message on their page, message on their WhatsApp. They will give you the whole details, how you take the lectures, recordings, and everything, right? Just take care. Have a good day.